So your SI joint has to be parallel to the S1 end plate. So you draw this line and then you go perpendicular to that line. That is your true SI joint coronal. All right. So that's the plane that we would be looking at. So the commonest finding that we would get in such patients is the presence of bilateral erosive sacroiliitis. So the erosions are very well seen on the T1 fat set. On the T1, we would see this fat proliferation, which is also part of the sclerosis profile. And the stir will show us marrow edema. So marrow edema is a marker of activity. The erosions confirm that this is an erosive sacroiliitis and confirm that we are dealing with an inflammatory arthropathy, and that would typically be a seroneg. And the T1 fat proliferation as a marker of sclerosis tells us that this has been around for some period of time. Now it may be symmetric, it may be asymmetric. You may see the erosions being symmetric, but the marrow edema is only unilateral. That can happen, and typically this patient will have left-sided pain more than right side. You may have burnt out sacroiliitis where erosions are there, and you can see them very well on the T1. There's a lot of sclerosis here, but there is no marrow edema. And you may sometimes get unilateral disease where there are erosions and marrow edema only on one side. Now all the bilateral disease, symmetric or asymmetric, unilateral marrow edema but bilateral erosions, burnt out, etc. are all very easy to diagnose, because irrespective of the asymmetry, etc., you know that it's bilateral sacroiliitis, therefore this patient has a seronegative spondyloarthropathy. The challenge is when we have a unilateral sacroiliitis. And what was the rule in the earlier lecture that I told you? All monoarticular arthropathies are infection unless proven otherwise, with one exception.